Um, excellent. Lindsay, can you orient me what slide we're on?
Yep, we are just on the beginning slide. Everyone was chatting in where they're from. So we've got folks all over the place. We have Joan Maxwell is on from Jawmere Health, Sherry Benz in Rhode Island, Dr. Hellerstein, Lisa Maurice with Consumers Advancing Patient Safety, Rosie Bartel, Dr. Gee, it looks like, from American Association of Kidney. So lots of people on and chatting away.
Awesome. Awesome. All right. And have you oriented everybody to using Zoom?
Not yet.
Okay. Why don't we go ahead and get started?
Okay. Okay, well, everyone, we are using Zoom today. If you haven't been on before, you should see my screen presentation. It looks like a lot of you have already found where the chat box is. So please chat in any questions or comments you have throughout today's presentation, but also a very interactive virtual meeting here as well. So please feel free to speak up when you would like. And you can, if you hover over your screen, should be able to see this toolbar where you can mute yourself, start your video, and you can also go to Manage Participants and click Raise Hand if you would like to speak up or ask a question as well.
Wonderful. Can you go to the next slide, please, Lindsay?
Yep.
So the PFAnetwork, our virtual meeting, I'm so glad to have everybody together today, and I just have to apologize again for a little bit of the distraction and interference. I'm actually on my way to my oncology check-in, so the patient life never stops, right? The PFAnetwork is a program of PFCC partners. PFCC partners recognizes the quality of healthcare can really be improved, and we can indeed reinvent the healthcare system through partnership with patients, families, healthcare organizations and systems, as well as our clinicians. So together we can do more. Next slide, please. The vision for the Patient Family Advisory Network was really came about organically through several meetings with advisors from across the country who desired an opportunity to continue to be engaged with one another and build the community of engagement overall. So with that in mind, we created the network with a vision to meet that sense of community and as well as to exchange skills. So what kinds of things and opportunities and learnings can we share among this community of advisors to raise the capacity of all advisors to partner with our health systems and healthcare stakeholders. Next slide, please. I have spoken with a few advisors within the network, and there seemed to be a little bit of confusion about sort of what the connection between PFCC partners and the PFAnetwork is. And so I thought I'd share this slide just kind of briefly, which describes our overall organization. And this would be really founded, as you see at the bottom, in the Patient Family Advisor community. So the work we do with the PFAnetwork really feeds our vision of what's possible in reinventing the healthcare system and in moving the organizations we work with forward in engaging patients and families meaningfully from the bedside to the boardroom. So I just kind of wanted to share that and let you all know how fundamental these calls and the Yammer community and the engagement opportunities are really fundamental. All of you are to our purpose within PFCC partners in moving forward authentic engagement opportunities. Next slide, please. Just want to make sure we're on the same page. You're on the map?
Yep, I'm on the map.
Excellent. So I shared this a little bit ago, but I wanted to share an updated version that our wonderful admin, Laura Jackson, worked on for us to kind of give you an oversight of where we are located regionally as a community. And this is specific to the registry. So all of you who completed the membership survey and are participating in those engagement opportunities coming forward, that is where we are represented nationally. There's about 160 folks now in that registry, so it's growing all the time. We invite you to share that opportunity with advisor colleagues as well. Great. Next slide, please. We also, under the community banner, wanted to raise your awareness again of the Yammer community. That's our online community for PFAnetwork. There's lots of great conversations going on there constantly, and new ideas, new thoughts, even challenges for us as a community as we move forward. It's also the place that we share the information on our work groups, so the ITP stack, for instance, as well as the compensation work group, which is working diligently to uncover some of the standards around compensating advisors for their efforts and working towards a set of recommendations moving forward. But this is really our opportunity to connect with one another and for you to float ideas to other patient-family advisors. So I encourage you to check in. If you are not currently on the Yammer community, if you just enter your name and email into the chat box, we'll be sure that you get an invitation directly. All right. Well, with that, we'll move forward and invite Joan Maxwell into the conversation. And I'll give Joan just a second to introduce herself, but I wanted to just level set, why we asked Joan to speak with you today, to speak with the group today. We've been talking about engagement opportunities as that third part of the mission for the PFAnetwork. And the engagement opportunities come from all kinds of healthcare organizations and systems, research teams, measurement development teams, again, just all kinds of projects, looking for patient-family advisors who may have a particular lived experience, or maybe they perhaps represent a particular vulnerable population or a region. By completing the membership survey, that's how we can connect you with those opportunities. So I thought it might be helpful to hear from Joan, who is someone that we connected to the engagement opportunity the National Quality Forum was offering around the opioid crisis. So Joan, thank you so much for taking time to visit with us today. I will ask you just to introduce yourself, and then if you want to carry on or if you'd rather get some questions, just let me know. Joan, are you on mute?
Yeah, Joan, you might be muted. I see you on, I'll unmute. Joan, are you there?
Hi, can you hear me?
Yeah, we can.
Okay,
Yay,
good.
thank you so much,
Yay.
Joan.
So sorry about that.
No problem.
Today's a day for technical difficulties, I guess.
Right?
So I've been, a part of this community, I guess, for a little over 2 years, and Libby had called me because of this opportunity at NQF, and I have to say it was a fantastic experience. And, I had, and I was the only patient in a group of probably about 60 people. So I was kind of the voice of the patient. And the people in this particular opioid stewardship task force came from both the public and private sectors. And it was a very, very kind of impressive group. It was, NQF is in Washington, D.C. So I went there for a meeting kind of early in the process. And it was about a 9-month process, and we met via phone on a regular basis. And Libby had sent me some questions in advance of speaking to you today, and one thing she asked was, you know, kind of how I felt about it. And I have to say that I was a little bit intimidated because it was such an impressive group of people, but they were very, very welcoming. And I think even in the 2 years that I've been doing this work, I've found more and more acceptance of the patient voice and welcoming of the voice, and people wanting you to speak up and really wanting to hear that patient perspective. And one little detail that I want to mention is I don't have any medical background. I am totally a fashion girl. And so, like, they use a lot of acronyms and expressions that I don't understand. And over the course of working with them, I did get comfortable with asking, because otherwise I got very lost sometimes in terms of what they were talking about. So I really encourage everybody to just, you know, tell the truth that you don't know what it is and ask for clarification. So the objective of this group that I was on was to learn from national leaders about the public and private sector efforts to improve opioid stewardship, pain management practices, and patient outcomes. And then to identify practical strategies, tools, and resources to address common barriers to opioid stewardship. And then to learn innovative measurement strategies to track, monitor, and improve opioid stewardship and related patient outcomes at their facilities. So they published a playbook at the end of this 9-month work group, and that has kind of a lot of the information and conclusions that this team reached. And so my perspective, I think, was as a patient, you know, having had 9 surgeries and being prescribed opioids and not being even told that it was an opioid. And then also I have a brother-in-law who is addicted to opioids as a result of failed back surgery. And so I also have the perspective of being the relative of someone who has not had a good outcome. And so I think it was helpful for them. In fact, in the first meeting, they asked me they had 3 people speak at the initial meeting, and one was the Surgeon General of the state of Pennsylvania, one was the head of pharmacy for Kaiser, and then me. So talk about intimidating. That was incredibly intimidating. But I just had that, you know, patient and family perspective. And afterwards, I had so many people come up to me and say, you know, thank you for being so honest, and thank you for asking all the questions that I asked, because I said, I'm not the person in this group with the answers, but I'm the person with the questions. So I guess my advice is, because I think I was so intimidated to speak at that first in-person meeting, I really prepared well. So I literally wrote out my speech. I practiced on people. I just really wanted it to be impactful and meaningful. And then we had a practice session with the woman who's the Surgeon General and this pharmacy head from Kaiser. And I basically went over with them what I planned to say, and I asked them for feedback. So by the time I got up in front of that group, I felt pretty confident that I had a concise, meaningful way to kind of express the patient point of view and ask the right questions. So I think my advice when we're given these opportunities is that we can like make a difference in terms of the future of patient engagement. So if we do a really good job and are really focused, then there will be people in that room who will reach out later and want patients on projects they're working on, and it will just like spread. So every single time we have an opportunity like this, like I am really trying to be thoughtful, be prepared, like reach out to people in advance if I'm speaking and get feedback on exactly, you know, what the message is. And so I just, since then, I'm on a committee with the CDC, and it's because Christina Makosa was on that NQF committee and we worked together. And so she then had the idea to include a patient on the CDC opioid task force and asked me to join. So that's what I'm saying about like, it can, you know, snowball, like our efforts can, you know, and then I also got asked, there was a woman in the committee, Alice Bell, who is with the American Association of Physical Therapy, and she had me join a Facebook Live conversation panel with all physical therapists talking about pain management. So there's so many opportunities out there. There's like so much work for us all to do. And this organization, we're so lucky to have it because it's getting us involved in all this, you know, really important work. So I guess that is, I can open it up to questions if anyone has any, or if anyone else has experiences like this that they want to share. I still have a lot to learn too and would love to hear from you.
Thank you, Joan, and I'll encourage others to speak up as well and get your questions in line. I really just was listening to your description and really saw all 5 of the core competencies of effective advisors in your statements. And so we are super glad to support you and super glad to have you representing the PFA network out there. And I'm just curious if you have any thoughts particularly about how this, or anybody on the call, how this organization can further support and build opportunities such as the one we've heard about from Joan today.
Is someone on the line?
Go ahead, Joan.
I'll just jump in and say that I think that what we need from you is, I mean, you are so well connected and so well respected by some of these, you know, IHI and NQF, some of these larger organizations that are creating lots of groups like this. So advocating, as always you do, for a patient being in the room is really great. And then also I felt like, Libby, you did a really good job of preparing me and letting me know, you know, kind of what the purpose of this was, what it was going to be about, you know, kind of how to think about my role. And so that kind of mentoring, I think, is really important, because when you take these on and you're like on these calls with all these like doctors and heads of hospitals and industry, you know, experts, researchers, it is a little bit intimidating, but our voice is really important. And so we have to speak up and help them help us, you know. So
Right.
anyway.
Right. Well said. Any other questions or thoughts? Anything in the chat box, Lindsay?
No questions at the time. Just one comment from Teresa Masters, talking about in terms of pain management, the last few conferences that she's attended, she spoke from the floor in support of CBD for that pain management. That's the only, yeah, any other questions, I welcome them in the chat box as well.
You know, and that's one thing I think we can really encourage is that they don't talk about it as, you know, opioids, but they talk about it as pain management or returning to function and really partnering with patients and educating patients early in the process, not telling us when we're in the hospital gown and pre-op what our options are, but having those conversations in the doctor's office before, when we're not as scared as we are right before surgery and we're able to have meaningful conversations. And so that's a really good point, calling it pain management, and also all the excellent choices that are out there that aren't opioids.
Yeah, I think that's really important in terms of opening the conversation and that subtle difference, rather than alternative therapies, but really pain management as a larger encompassing. It's a subtle difference, but it sets the conversation off in a different direction for sure. And Lindsay, I'm just wondering, I know Joan and I both had difficulty getting off mute because it was mute on entry. Have you taken everybody off mute?
I haven't, but I can. So,
yeah, because I think
yeah. Now everyone is unmuted if you would like to speak up and share or ask questions of Joan.
I would like to share.
Great. Who's this? Can you identify yourself?
This is Terry Masters, and I not only speak from the floor at conferences, but I speak directly to practitioners. Some do not want to hear what I say. Some do not want to be the first one in the department to mention CBD as pain management, and others, they're afraid to bring it up because they don't understand that it is a viable legal addition to palliative or pain management. And I don't stop trying, but can we not get it more openly discussed without fear?
That's a great question, Terry. And I think that, you know, conversations like we're having today in terms of how we move forward and the engagement opportunities that we have. I mean, I can say that we are getting more and more requests for patient and family advisors to work on the opioid crisis, and I think that's our window to really expanding the thinking around pain management. I appreciate. Thank you.
Yeah, we ourselves have to understand it. So if anyone has a question, ask it and identify your own fears or prejudices. The only way we can do that.
Yeah, yeah. Lots more opportunity ahead for sure. Thank you. Any other comments or questions for Joan? Yeah.
Dr. Hellerstein here.
Hi, thank you for joining us.
Okay, I just want to say to Terry and to Joan, being a patient family advisor and having a voice means a lot. I myself am a retired general dentist. The American Dental Association has taken a very strong stand and just had some legislature passed on opioid addiction. I continue, and last evening I was at a local dental society meeting. I've been a member of the American Dental Association for 42 years. There are organizations, and the one thing that I always did with every one of my patients was, you need to communicate to me. I was one who was very restrictive in writing prescriptions for pain medication, pain management. And I feel that there are lots of practitioners. Yes, there's lots of abuse within the healthcare profession itself that many people may not be aware of. But many, one of my classmates at Temple University Dental School, after 1 year after graduation, decided to use and abuse, and John is no longer with us. He would have been a wonderful dentist. But communication, and I think your voices and everybody in the network, communication has always been the key. After retiring for health reasons from dentistry, I went on to teach part-time at a local community college in the health, physical education, and nursing department. And one thing that I always tried to instill in my students was communicate to me. I don't know what's going on in your mind and all the things that you're dealing with. And as a PFAC member previously in Pennsylvania, now I've moved to New Jersey, Fox Chase Cancer Center. I was one of the few healthcare providers, except for the hospital staff who attended the meetings. And yes, the people spoke up, and we made lots of changes.
Yeah, that's the exciting part of this work, is that opportunity. And I agree with you 100%, you know, speaking up and continuing to voice and have voice in the system, but as well open space for others, for patients and families, other patients and families who maybe don't have that opportunity, and continually make space. And that's really our purpose as the PFA network, is to ensure that every patient and family member who desires to have a voice in the system has the space, has access to skills development and capacity building in that role, and access to engagement opportunities. So I thank you both for sharing, and I thank you, Joan, as well, for always, as I said, representing the PFA network so positively, and doing your due diligence to prepare for that, for every engagement opportunity. I really appreciate the effort that you put into that. So thank you for sharing that today.
Thank you, Libby.
Absolutely. So I'm going to move us on a little bit into our some of the skills exchange opportunities and engagement opportunities that we have. I want to make sure we don't run out of time, because there's a lot going on, and we need your voices. So next slide, please, on the HIT PFAC. Lindsay, do you want to give a little update?
Sure, and actually I'm going to see, I think Rosie was on, and I had asked her to give an update last month, but we got a little interrupted there. So Rosie, would you mind giving an update to the group about the going-ons of the ITPFAC?
Sure. The HIT PVAC is working on, with open notes, to develop better communication between patients and their physicians or healthcare providers through open notes. And we're looking at some just ordinary things like how hard is it to reach the open notes? How many places are using the open notes and really using them well? And just looking at different ways. We're working on letters to go to vendors, which would be like the vendors of the IT portals, patient portals, and also to organizations that use patient portals. So we've created 2 letters that will be going out, and those letters have a place where we've listed the challenges for us and what we feel their challenges might be, and how we might be able to cooperate together to develop a stronger patient portal that is more patient friendly, because I think many times the patient portals become burdening for patients and they quit. Once it's past 1 or 2 clicks, people say, I don't care, I'm not, I'm going to find a better way of getting my information. And I guess, I'm on Yammer, and if you ever have thoughts about this, please send me a note so I can take it to the group, because we meet quarterly, and we continue to work in between those quarters to try to improve patient portals across the United States.
Wonderful. Thank you, Rosie, for that update. Yeah, and I just to add on to that quickly, those letters that Rosie mentioned are kind of our first deliverable and outcome for the council. So we're really excited about that. And those are in process to, like Rosie said, inform vendors and health systems on the issue of navigating the portals. Like Rosie mentioned, that was kind of the first area of issue that this council had seen as being something that we wanted to focus on. So we're really excited in the next couple of months to get those letters out and hear back from vendors and health systems on future steps that they might be taking forward. But thank you, Rosie.
Teresa had a question, and my response to that is that I find that I first had my first open note portal situation in the last month, and it was just like really refreshing to be open up that note and to like read exactly what I thought I heard the doctor say, but now it's in black and white. And I can now say to myself, yes, I was right, or no, I missed that. I really didn't understand that, and I might have another question. And you have an option of sending a message back in another part of the portal. And that's the piece that we might want to try to fix, is that you can't send a message back from the open notes. You have to go to a different part of the portal to send a message back. So I think that these are situations that we might want to look at in the future.
I completely.
Thank you, Rosie.
Thank you for that.
Oh, sorry. We just had one more question, Libby, in chat from Dr. Hellerstein, asking if Rosie can post any files on this topic to Yammer. Yeah, I think we have a little bit of research and documents that we can share. So I think that is definitely possible. Yeah.
Absolutely. And you might throw the Open Notes website into the chat box. That might be helpful too. Thank you so much, Rosie, for that great overview. And I will also say and invite everybody who's on the call, if you've got, pressing concerns around health information technology, whether it be patient portals or whether it be other, apps that you might be using, or if you've got other priority areas that you'd like to bring forward to this ITPFAC, we would be more than happy to hear that. So you can email them to us, you can put them in the chat box here, you can load them up to Yammer. But we really, want to be reflective of the entire community. So we'd love to hear those thoughts as well. Great. All right, Lindsay, if you take us on to the compensation work group update, I'll go ahead and provide a quick update there. So the compensation work group, again, is we're about, I think we've had 2 meetings heading into our 3rd. And this group really, again, organically grew out of a topic of conversation that's very much present in the environment, both for health systems and teams that are engaging patients and family advisors, but also for us as an advisory community. And I think that was really important for us to convene a group to think about very intentionally compensation and how that affects this is such a, as I've been calling it, such a hairy animal, because there's so many different implications for around when we're considering compensation for advisors. And so this work group, which I really appreciate the dedication to the work group members for their efforts so far. We started with an environmental scan, so that was an effort to sort of understand what's going on out there. How are people currently being compensated, if they're being compensated, if they're not, you know, sort of what are those barriers, and what are some of those even budgets look like. So we've collected all of that information. Laura is working hard to compile it into an organized fashion. But a couple of other more recent updates. The National Quality Forum, who has really been a tremendous supporter of PSCC Partners and the PFAnetwork, is very interested in this conversation. So they are dedicated to engaging patients and families in all of their efforts, much as what we heard about from Joan. Well, Joan, although her travel costs were offset, she did not receive a stipend for that effort. And NQF is really trying to figure out how they do this. How can they do this better so that they get more representation in their work teams? So we recently have had a conversation, and I'm very pleased to say NQF will be joining some of our work group calls to learn alongside with us, you know, how we can move this conversation forward. At the root of this work group is the relationship of compensation and inclusion. It was really an eye-opener for myself and several others when we heard the concept that volunteerism by itself is privilege. And if we are really serious about representing vulnerable populations in our advisory efforts, that we really need to take another look at the compensation conversation from that lens. And so that is really grounding the work of this work group moving forward. We decided on our last call that the outcome of this work group would be a set of recommendations from the network around how health systems could consider compensation for advisory efforts. Excuse me. And we have created a request for resources, and I would include all of you on the call to share with us any resources you have or experiences you have around the compensation conversation. So that's an update. I'll open it up for any questions at that point or comments. Do we have any other members of the compensation work group on the call that might want to interject?
This is Rosie, and I'm I'm involved in that work group, and I've done a lot of requesting resources by verbally requesting resources over the last month, and it seems that I've gotten a lot of the same response from hospitals and healthcare organizations, is that they want to do it, but they sometimes feel uncomfortable asking people to fill out W-9s because that's the best way for them to do it. And so they've made this, and what I've learned is they've made decisions for volunteers saying, well, they don't want to fill out a W-9, so they don't, that's why we don't do it. More than, and when I asked them, did you ever ask them, did they want to fill out a W-9? They said, oh no, we just decided that. And so I think by me even asking them the question, I've already turned on light bulbs, because two of the organizations are now looking at this where they had never thought about looking at it before. So
Wow.
I think it's just, sometimes we are not asking, we're not asking the right questions, or we're not encouraging them to go beyond their, they have a limited thinking, and so they think that a W-9, they think that a person doesn't want to get a check or another form of income, or, and that's why they don't want to do this. And logic tells me that, most people, are okay if they're going to get some compensation to know it has to go through the right channels, in our government.
Yeah. That's that old, I always call that the assumptions of kindness. So I think they actually come from a good place. We see this with a lot of organizations. Oh, advisors won't want to do that, or they won't want to participate in that, or they're not going to want to travel that far, or what have you. And so those assumptions reduce opportunities. So you're bringing up a great point and a great conversation to have with our organizations and health systems.
But I said this at our last meeting, that I think they don't, that they don't know where to put it, where to get, how to take care of it in their budgets and things. And I think that's part of it. But I think the other part of it is they don't know how to put it into their systems, and and how to make it work. So I mean, I think I really spurred some thinking in two different one very large organization and one pretty semi-large. So I think sometimes we just have to, as Joan said today, we have to ask the questions. It's not, we don't always have the answers. And as a patient, we have more questions than answers. And so we have to ask those questions. We have to ask them. And that's what I think is important.
I would agree.
Hi, this is Desiree. I just have a quick comment. I know in my organization, it's always been told to me, we don't do that here. We don't pay our volunteers, that thing. So we have a competing hospital right down the street, and they, pay their advisory board members per meeting to compensate them for childcare and gas and what have you. And so most recently, I was with a meeting with our leadership on another topic, and just in casual conversation over our lunch break, I brought up our work group and what we were working on, and I started telling the group, and I knew he was sitting there, what we were working on and what their thoughts were on it, and he was really quiet, but I could tell he was listening. And I mentioned this competing hospital. I said, well, they're doing it, and they have a budget for it. I said, and they really have great engagement because it eliminates the barriers. And as soon as I mentioned the competing hospital, his eyebrows went up, and he was like, well, what are they doing over there at so? And I started explaining to him, and I said, if you want, we can have a side, line conversation about this if you're interested. I said, I really think we could pull more diversity if we just think about it. And then he's like, okay. But it was almost like pushing that seed of competition. I took that opportunity to do that. And, I don't know if that was the best tactic, but it got him to thinking, whereas it was always a stonewall before that.
Well, I don't know that it's a bad tactic. I mean, I think, everybody has their motivations, and not for me to judge in terms of how you run a health system successfully and sustainably. So why not? I mean, if that's a priority, and we talk all the time about really attaching our advisory efforts to the strategic priorities and initiatives of the health systems as a lever for deepening that engagement. I mean, I think that's as authentic as it gets. Thank you so much for that, and thank you for always moving the conversation forward.
Oh, you're welcome.
Any other thoughts or contributions to the compensation work group?
Well, I do. This is Terry.
Hi, Terry.
So our group we were just expected to attend. Those who were not employed, that are employed, were able to come in, some on their own time, some compensated time. But the patients represented, no, nothing at all. I have been a volunteer within the system in another department, another area. At least got an ID card, which allowed me to buy stuff in the bookstore at a discounted price, but not in relation to patient advocate. And I can't imagine the resistance, but I was never able to break through. What I'm finding now is too many levels when you're in a medical situation do not want to hear a word from the patient, and they resist patient input. And it blows my mind because they create space as they wish it to create, using experts in design and lighting and construction. And then they open it up to the patient, and it doesn't fit at all. The light's shining in the eyes, the air conditioner is blowing on the head of the bed. And so I did have a walkthrough prior to an opening, and I was in the bed, and I did mention these things. And one of the physicians in the walkthrough said, I want to see for myself. And he got on the bed and he said, yeah, the light's in your eyes, the air is blowing on your body, and this is not comfortable. But why was there not somebody in the room at design conception who, it looks beautiful, but it feels terrible. So
yeah. Well, maybe with your health system, Terry, it might be useful to try Desiree's tactic and talk about all of the other organizations that are including the patient voice in construction and design projects. That might be helpful strategy.
Some places do have patients sitting in at that level before they even put the pencil on the paper.
Right. Yeah, so you might be able to take those examples back to the organization you're referring to and perhaps make a change for the future.
Well, if we could know where they are and who they are, I don't always have the ability at that moment to get the name of the person who's speaking from the audience, or I don't know. I don't want to feel as frustrated as I do get, but when I see this level, patient family centered advocacy being minimalized, it's sad.
Yeah, I would agree. Well, please feel free to post what you need for those examples to the AMR community, or send them in to us, and we'll post them for you so that you get some of those examples that would be helpful to you in those conversations.
Thank you.
Sure.
If I might interrupt, this is Charlene from Salinas.
Hi, Charlene.
Hi. I had a very similar situation that I experienced. They were opening a new Stanford facility in Emeryville, which is a few miles away. And so I was invited, my life partner and I were invited to act as patients for this run-through prior to opening. And so I was ushered into a room, and as I explained at the time that I was heart transplant, so I decided that why don't we test cardiac arrest while we're in this room? We discovered that the only way the blue card could be summoned to that particular room in Emeryville, it had the request had to go through Stanford proper.
Oh, and, wow.
Yeah. a big omission right there, because of course, yeah, by the time the nurse who was pretending to administer CPR was like totally exhausted, and I was dead. But anyway,
Right.
but my point is, asking patient involvement at that particular level obviously caught a huge oversight on design. And anyway, just thought I'd share.
But
I'm glad you did.
But if she had been in the design consultation before the gravel was poured, it might have been avoided.
I agree, and I think that's the opportunity. And as we, you know, this work can be frustrating sometimes, and I hear the frustration in your voice, Terry. But I think we also need to acknowledge the journey that we've been on to engage patients and families. And you know, this hasn't happened overnight, and we still have a long way to go. But to Joan's earlier point, gosh, there's more opportunities than you know we can fill right now, which is a wonderful hallmark sign that we are moving further upstream and will continue to do so. But that doesn't happen without our awareness and our bringing forward examples. So I appreciate both of you and your comments. I think we're getting a little bit short on time, and I want to hit these engagement opportunities. So if you go to the next slide, please, Lindsay.
Yep, and I'll, as you go through them, Libby, I'll put the links in chat.
Fabulous. You can also find all of the links and the information, more information on each of these on the website and in the Yammer community. So I just want to clarify. We get two kinds of engagement opportunities. One is a specific request for us to identify an advisor within the PFA network who has a specific lived experience or is a region or represents a vulnerable population with a skill set. And we provide that preparation that Joan was talking about. Those are what we call directed engagement opportunities. And we're constantly filling those. The second type of engagement opportunities are more broad and what we call all calls. So these are the opportunities you see on the slide, and those are available to anybody and everybody who would like to participate. So the first is the Patient-Centered Primary Care Collaborative Conference, which this is work that's heavily involved in the Transforming Clinical Practice Initiative. So any of you who are partnering on advisory programs in the ambulatory center in particular might find this a very robust conference to attend. There are some scholarships available, and the conference is November 8th. Again, you can find the links Lindsay's putting into chat, and they're also on the PFA Network website as well as in the Yammer community. The compensation survey, if you haven't already completed that, it won't take you more than 5-10 minutes tops to share your own experiences, whether you've been compensated or whether you haven't. It's important for our work group to understand the experience of the entire network so that we can be fully representative. So I not only invite you, but implore you and maybe even beg a little bit for that 5 to 10 minutes to share your perspective there. Project Achieve is a project that's been going on around the last 5 years or so. It's directed from the American Hospital Association, and they have completed their research around transitions of care and are really interested in getting out what they've learned. So sharing with all of us, they particularly would like to connect with patient and family populations that would benefit from learning along with them about care transitions. And so they also have an open survey. I took it just the other day. I think it took me 2 minutes to ascertain how they can best, share the information that they've learned. So if you have a couple of minutes to jump on there, that's fantastic. And then the American College of Cardiology also got in touch with us. They're having a multi-stakeholder meeting about heart failure and how they can appropriately measure those outcomes for heart failure patients. So if you have lived experience with heart failure and are interested in traveling to Washington, D.C. for this meeting, the details again are on the website and in the Yammer community. And you can respond directly back to their contact and arrange participation in that meeting. So those are 4 that are active right now in terms of those all calls. I will also say that we have measurement development directed engagement opportunities. So if you have interest in participating on an expert working group, which is a multi-stakeholder group, around on the topics of either, these are all screening measures. So screening for depression, screening for body mass index or BMI, and screening for high blood pressure. So again, if you have lived experiences in any of those areas and are interested in participating, please send me an email at Libby@pfccpartners.com, and we'll have a conversation, and I would love to talk with you about that. All right, and then finally, I just wanted to share with you the engagement opportunities. So again, these numbers are reflective of those directed engagement opportunities. So those we've matched 40 patient family advisors with specific engagement opportunities. We're pushing that all of those engagement opportunities come with some stipends. We haven't achieved success on all of that, but that is something that's important to us. We, on a number of them where we have the ability, PFCC Partners is offering that stipend. So again, I encourage you to, if you haven't already completed the member network survey, that's where we're drawing from for these directed engagement opportunities. All right, well, I think we're actually 2 minutes over the top of the hour, but I'll stay on for another moment if anybody has any final questions or thoughts. Otherwise, I appreciate your time today, and we look forward to talking with you during the month on Yammer and next month on the call.
Thanks, Libby. Thanks, everyone.
All right, great. Thank you.
Thanks, Libby.
Thanks, everyone.